There are very few parts of the body that you can't get a needle to treat. So cancer pain, being able to kill nerves, say somebody with pancreatitis or pancreatic cancer, trying to just knock out the nerves that allow them to live their lives, the last months of their lives, pain-free, is an important part. There are, depending on where the cancer is in the body, there's always a set of nerves that go to that. If we can identify, and if it's a localized set of nerves, and using substances, alcohol being the mainstay, to destroy those nerves, we're able to then allow that part of the body not to feel anymore, so the patient doesn't have pain. Again, it would be in a case where we know pain is not a red signal sign to the body to say that something bad's going on. We know what's going on. There's a cancer in the pancreas. It needs to be, it can't be treated, it can't be surgically removed. Well, if we can do a block and just remove the nerve impulses from there, then the person will not have pain. So pancreatic cancer and celiac plexus blocks being the procedure, probably the most common one that we perform. DEA will get in contact with us if they think that there is something suspicious going on, meaning specifically a prescription that we wrote that's going on. We've had calls, one of our patients that was before we had the ability to do urine tox screens and before we had the state monitoring system, got a call from Dade County police down in Florida. They had been following one of my patients who would come to me, get his prescriptions filled. He had had 3 surgeries on his neck, 2 surgeries on his lower back, would fly down to Florida, sell all of his medications, live for the month on the money that he sold for his medications, come back up the next month, get his medication, and repeat the process. He did not need them. And we were totally tricked. What he fooled me is he walked with a cane, he had surgeons that still wanted to operate him, he had a horrible looking MRI and had physical exam that had weakness. He was a very persuasive patient. And he was able to use the medications. This is going back about 15 years. The ability to fool pain providers now, myself included, is much more difficult with the urine tests, with everything else that we have monitoring wise now. Much more difficult thing to do. I would say 90% of drug taking patients I can pick out. 10%, still doing this for 20 years. I think there's probably about 10% of people that are still pretty good actors and can fool me and using these other things, the urine tests. I mean, most patients that are drug seeking will define themselves very quickly. Took too many pills. Doctor, I'm out of pills, but I gave you a month's supply, but I'm out at 3 weeks. Okay, you have your choice. Either you can come in, I'll give you another month's supply, and that's the last prescription I'll ever write, or you wait for your month and I'll see you then and we'll get you back on track. The drug seeker will be there in the office to get the last prescription and be flying out the door. And that used to work before the state was watching this, but now any pain provider looking at this can see what was going on by just running the PMP, which is the iStop, which is the prescription monitoring system for the state, can see this, right? And hey, what happened? You're seeing Dr. Stamatis and looks like he gave you a month prescription 3 weeks into it and then you haven't seen him again? Oh, yeah, he isn't seeing me. So we're able to pick it up. So the noose is getting tighter around people that are using the medications illicitly. So it's a little bit easier for us to catch those people. Feel sad for them. And they actually go to our addiction psychologist. The last thing you want to do is just put this person on the street because they'll just do it to somebody else. So with our addiction psychiatrist, we're able to address some of the issues and sometimes get them under control. There's some new substances on the market. Suboxone is one of sort of a methadone replacement, so it's a long-acting narcotic to keep people that are using street drugs not have the cravings for those. And the FDA just approved, I think 2 weeks ago, a subcutaneous implant, which gives you 6 months of the Suboxone. So in a patient that before they're jumping to other places, this is another option, sort of keep the cravings away and minimally impact their lives. Don't have to take pills every day. Once every 6 months, just have to have the implant that's just underneath the skin, which is done in an office procedure, taken in and out very quickly. I think it will in the long run. The problem with addiction treatment is still the same thing. Patients got to want it. Patients got to want to not take their street drugs. Patients have to want to be better. And unfortunately, some patients just aren't. So addiction treatment still is dependent on, just like trying to quit smoking, just like trying to quit anything else, that there is some will on the patient's side to actually want to do this.